is Dr. Arif, and I'm your tutor for today. On this channel, we simplify medical knowledge from surgery, medicine, ops, gynecology, obstetric, and related specialities so that learning medicine becomes easy and approachable for everyone. With that said, let's jump to today's session. This is part 3 of clinical anesthesiology and pain management. The learning objectives of today's session are basics of anesthesia. Underneath, we will learn about definition, purpose, phases of anesthesia, depth of anesthesia, monitoring during anesthesia, Aldrete score, types of anesthesia. And since we know there are two types of anesthesia, local anesthesia and general anesthesia, in this lecture we will study in details about the general anesthesia along with its types like parenteral general anesthesia with mechanism of action and clinical applications, and inhalational general anesthesia with mechanism of action and clinical application. Now let's jump to definition and basics of anesthesia. The word anesthesia means no sensation. It is a voluntary process inside which the anesthetist gives anesthetic drugs to induce the anesthetic states. And there are a triad of anesthetic states like unconsciousness, patient will be unaware of self and environment and is achieved by sedation. Analgesic, patient does not feel pain. Amnesia, patient will not remember the procedure. And then there will be muscle relaxation and autonomic stabilization. Autonomic stabilization means that the vitals like pulse, blood pressure, and temperature will be stable. As a side note, you should know that anesthetic state cannot be achieved by a single drug. That's why multiple drugs are used, and it's called balanced anesthesia or multimodal anesthesia. Now, what is the purpose of giving anesthetic medicines to achieve anesthetic states? To make surgery tolerable for patient and manageable for surgeon. Now, phases of anesthesia. There are 3 phases of anesthesia: induction, maintenance, and recovery. In the induction, patient enters the anesthetic state and following drugs are given. The number 1 is induction agent. Induction agent causes loss of consciousness, and most commonly induction agent used is propofol, and thiopental and methotrexate is also used in rapid sequence induction. We will talk about this in the coming lecture. Etomidate is a drug of choice for cardiac unstable patient, and ketamine is a drug of choice for patient with shock or asthma. Second drug that you have to give during the induction is analgesic. It means to make the procedure pain-free for the patient. And here is some example like fentanyl and morphine, which are strong mu receptor agonists. But however, you can also give partial mu receptor agonist like nalbuphine and toradol. Second drug that you have to give is to reduce anxiety and cause amnesia. Most commonly, midazolam is used, which is ultra short acting benzodiazepine. Then muscle relaxation. For muscle relaxation, depolarizing and non-depolarizing agents can be used. Then sometimes you can use anticholinergic reaction to reduce salivary and bronchial secretion and prevent bradycardia. And as needed, some adjuncts can be used, like lidocaine can be used to blunt airway reflexes, ondansetron is used as antiemetic, and dexamethasone can be used as antiemetic and as well as anti-inflammatory. Why you want to use dexamethasone? If there had been multiple attempts of passing endotracheal tube, there is possibility and probability of injuring the trachea or upper airway, and it may lead to swelling and edema which narrows down the airway, or it may even completely block the airway. So that is why, to prevent this complication, we give dexamethasone. Now there is a typical induction combination like propofol can be given as an induction agent, fentanyl can be given as analgesic, and rocuronium is given as muscle relaxation. In most of the surgeries, these 3 combinations are being repeated. There is one type of the induction that's called rapid sequence induction, inside which ultra short acting induction agent like thiopental is used, combined with the rapid acting neuromuscular blocker like succinylcholine, which is also called suxamethonium. Now, what is the benefit of this? It allows induction within 30 seconds and allow intubation within 60 to 90 seconds. And when do you use it? In emergency situation when there's high risk of regurgitation or high risk of Mendelssohn syndrome or aspiration pneumonia, because stomach is full and there's high chance of regurgitation. Why? Because patient had not been having time to put him on NPO. So second phase of the anesthesia is maintenance. Anesthetic state is prolonged for as long as required. Typically, we use volatile type of inhalational general anesthesia combining with gaseous type of the inhalational general anesthesia like nitrous oxide, and it is used for maintaining depth of anesthesia for easy titration and rapid recovery. And the third phase of anesthesia is recovery, means the reverse of induction by redistribution from site of action. Now let's jump to depth of anesthesia. Depth of anesthesia is defined as degree of CNS depression, and there are Gudel's stages of anesthesia. In stage number 1, there is analgesia with amnesia, means patient will not feel pain and will not remember the procedure, but level of consciousness is impaired but not completely lost. In stage number 2, there will be disinhibition, excitation, delirium, violent behavior, irregularity in blood pressure and respiratory rate. The loss of consciousness is complete, but reflexes are exaggerated, and it is undesirable stage and must rapidly be passed. To prevent this stage, short-acting barbiturates like thiopental can be given. Stage number 3 is surgical anesthesia. This is a desired depth and divided into 4 planes. In plane 1, there is loss of eyelash reflex. In plane 2, there is loss of corneal and laryngeal reflexes. In plane 3, there is intercostal muscle paralysis. And plane 4, there is a shallow diaphragmatic breathing. Most of the surgeries are done in plane 2 and 3. And the fourth stage is medullary paralysis, which is a life-threatening situation. There will be respiratory and cardiovascular depression such as apnea and hypotension. So now, depth of anesthesia is needed to be monitored, and that's why we have some monitoring tools like MEC, minimum alveolar anesthetic concentration. We talked about this, that this is a measure of potency of the inhalational general anesthesia. In fact, it is EC50, that is the amount of the drug needed to produce effect in 50% of population. Then the second thing is bispectral index. This is a numerical index which is derived from the electroencephalogram. If it is 100, means patient is fully awake. If it is between 60 to 40, means there is adequate general anesthesia. If it is less than 40, it's very deep anesthesia where there is high chances of the medullary paralysis. But if it is electrically zero or electrically silence, this means that there is brain dead. So monitoring of the patient undergoing surgery during the anesthesia. Monitor temperature and prevent hypothermia. Second thing that you have to do is pain control and muscle relaxation. How you know that the patient is feeling pain now? The vitals will increase, the heart rate and blood pressure. And how you will know that the patient is gaining back his muscle strength? That is from the peak and expiratory pressure of the ventilator. When it is rising up, it means that the patient is gaining control of his diaphragm for spontaneous breathing. Then cardiac monitoring should be done, BP monitoring. However, drop of 20 to 30% mean arterial pressure during surgery in a fit patient is normal, but if it is more than 30% drop, in mean arterial pressure, then this is something worrisome for the anesthetist. And look at the oxygen saturation by pulse oximetry and tidal carbon dioxide concentration and inspired oxygen concentration. Now there is a very important score which is called Aldrete score. This helps to determine either we can now discharge patient from anesthesia care unit, which is also called recovery unit, so that the patient can be looked after in ICU or ward. Total score is 10 and there are 5 parameters and each is scored 0, 1 and 2. Now let's talk about the parameters. The first one is activity. If the patient can't move, it is scored 0, and if the patient moves two of his extremities, either upper limbs or lower limbs, then this is scored 1, and if patient moves all his extremities, it is scored 2. The second parameter is breathing. If patient cannot breathe, this is scored 0. If patient breathes but with some shortness of breath, with some dyspnea, this is scored 1. And if the patient breathes deeply and as well as cough freely, this is scored 2. And then circulation. In this circulation, we compare the patient's blood pressure with the pre-anesthesia blood pressure. If the current blood pressure of the patient is 20% of the pre-anesthesia blood pressure or baseline blood pressure, then this is scored 0. And if the current blood pressure of the patient in the recovery unit is 20 to 49% of the baseline blood pressure or pre-anesthesia blood pressure, then this is scored 1. And if the blood pressure of the patient in the recovery unit or in the post-anesthesia care unit is more than 50% of the baseline blood pressure, then this is scored 2. Fourth parameter that we have to look at is consciousness, means conscious level. If patient is non-responsive, then it is scored 0. If patient is arousable on calling, this is scored 1. And if patient is fully awake, it is scored 2. Then look at the oxygen saturation. If the peripheral arterial oxygen saturation is less than 90% on supplemental oxygen, then it is scored 0. If the oxygen saturation is more than 90% and on the supplemental oxygen, this is scored 1. And when the peripheral arterial oxygen saturation is more than 92% on room air, this is scored 2. So if the total score is either equal to 9 or more than 9, the patient is safe to be discharged from post-anesthesia care unit or recovery unit, and you can send the patient to ICU or ward for further look after. Now let's talk about types of anesthesia. There are two types of anesthesia broadly, which are general anesthesia and local anesthesia. General anesthesia is further divided into two types on the basis of route of administration, like inhalational general anesthesia or intravenous or parenteral general anesthesia. The inhalational general anesthesia is further divided into volatile inhalational general anesthesia and gaseous inhalational general anesthesia. Volatile general anesthesia is liquid at room temperature, and mnemonic to remember the drugs being present in the volatile inhalational general anesthesia are he dimes. He stands for halothane, E stands for ether, D stands for disflurane, I stands for isoflurane, M stands for methoxyflurane, E stands for influrane, and S stands for sevoflurane. Then there are gaseous form of the inhalational general anesthesia, which are nitrous oxide and xenon. Now, parenteral general anesthesia is divided into two types on the basis of onset of action. Like there is slow acting and rapid acting. The slow acting involves dissociative anesthesia, for example, ketamine. There will be opioid like fentanyl and benzodiazepines like diazepam, lorazepam, and midazolam. Like rapid acting includes yopental, methotrexate, propofol, and etomidate. Now, local anesthesia is also divided into two types on the basis of amide or ester bond. The ester group includes cocaine, benzocaine, procaine, and tetracaine, and amide group includes lidocaine, mepivacaine, bupivacaine, and ropivacaine. We will discuss about the local anesthesia in details in our next lecture. But in this lecture, we learn about general anesthesia along with its types in details. General anesthesia are seen as depressants. And how do they depress the central nervous system? By two ways. Either they enhance the activity of GABAergic neurons, which are inhibitory neurons, by stimulating it, or by increasing sensitivity of receptor to GABA, which is inhibitory neurotransmitter. GABA stands for gamma aminobutyric acid. Or there is another way that it can depress the central nervous system, that is by inhibiting the activity of glutamatergic neuron. Glutamatergic neurons are excitatory neurons by binding, so these drugs bind to NMDA receptors and block them. NMDA stands for N-methyl D-aspartate. And the drugs in the general anesthesia are highly lipophilic, so from bloodstream goes to highly lipophilic tissues like brain and spinal cord, induce anesthetic state, and then comes back to bloodstream, and they are metabolized by liver and excreted out of the body by kidneys. That's why the functioning of these two vital organs must be optimum. Now let's talk about the parenteral general anesthesia with some of the examples. Number one is thiopental and methotrexate. The onset of action of them are 20 seconds, and they are ultra short acting barbiturates, and the duration of action is 5 minutes. Now, advantages of using thiopental and methotrexate: they can be used as induction of anesthesia. Second, they rapidly diffuse out of the highly vascular tissues such as brain, liver, kidney, and redistribute it to fat, muscle, and other tissues. Therefore, their effects won't remain in the body for a longer duration of time. They decrease the cerebral blood flow by vasoconstriction and decrease intracranial pressure, so it can be used for patients with head trauma or mass occupying lesion in the brain. Fourth advantage of using thiopental and methotrexate is that methotrexate is administered per rectum in uncooperative pediatric patient or in mentally challenged person. Now, adverse effect of thiopental and methotrexate, which are ultra short acting barbiturates, their adverse effect can be reversed by giving flumazenil. And what are the adverse effects? They reduce pain threshold, causing hyperalgesia, means patient feels extreme pain on minor pain stimulus. There will be garlic and onion taste, and there is release of histamine, so that's why it cannot be used for asthmatic patient because histamine causes bronchospasm. It causes cardiac and respiratory depression. However, this effect is dose dependent. Now, injection of thiopental and methotrexate around the vein rather than into the vein leads to local tissue necrosis, ulceration, and gangrene. So to avoid these adverse effects, the solution is that 5 to 10 milliliter of 0.5% lidocaine is used to dilute the barbiturates locally. The second important parenteral general anesthesia agent is propofol. It is the most common IV agent used. It is used for rapid induction because it has rapid recovery due to half-life of 1 to 8 minutes, and therefore patient feels better soon after surgery. Advantages of propofol is that it decreases cerebral blood flow by vasoconstriction. Therefore, it decreases intracranial pressure and can be used for patient with brain trauma or mass occupying lesion. It can be used for induction, maintenance, anti-emetic, and day surgery. That is a type of surgery that the patient doesn't need to stay overnight. It can be used in burn unit or ICU when dressing wound is very painful. When it is used as maintenance in form of infusion along with opioid and neuromuscular blocker, then this is called total intravenous anesthesia. Why opioid is used in total intravenous anesthesia? Because opioid is used as hypnotic agent such as ultra short acting mu-receptor agonists like remifentanil. And propofol doesn't cause release of histamine just like ultra short acting barbiturates. Therefore, it can be used for asthmatic patient. Now, adverse effect of propofol. It causes vasodilation which leads to hypotension. However, the severity of hypotension is dose dependent. It is painful on injection. If you want it not to be painful on injection, then use a large vein or use local anesthesia or dilute propofol with injection water. Third important adverse effect is respiratory depression, but it causes depression of upper airway reflexes. Therefore, it is very helpful during intubation and laryngeal mask placement. Why? Because it blunts the upper airway reflexes such as cough. Fourth important adverse effect is cardiovascular depression, and there is one syndrome called propofol infusion syndrome. When there is high dose and prolonged administration of propofol, this leads to inhibition of mitochondrial fatty acid metabolism, and the symptoms which appear in patient are bradycardia, heart failure, metabolic acidosis, rhabdomyolysis, and enlarged and fatty liver. The next parenteral general anesthesia agent is etomidate. It causes rapid induction within seconds and rapid recovery. 3 to 5 minutes is the duration of its action due to rapid distribution, and it has less cardiovascular depression, so it is preferred for patients with coronary artery disease, cardiomyopathy, cerebral vascular disease, and hypovolemia. But important side effects of etomidate: it causes adrenal suppression by inhibition of 11 beta hydroxylase, which normally converts cholesterol into cortisol, and this adrenal suppression lasts for 4 to 8 hours. It is painful on injection, so to make it painless during injection, you can use a large vein, or you can add local anesthesia, or you can dilute etomidate with injection water. It does not have any analgesic effect. The most common side effect is nausea and vomiting. In some patients, it may cause myoclonic movement. The next parenteral general anesthesia agent is ketamine. It has a rapid onset, less than a minute. It has rapid recovery, and the advantages of this is that it increases cerebral blood flow to increase intracranial pressure, but it cannot be used for patients with head trauma or mass occupying lesion in the brain. Can be used for patients with hypotension and asthma. Why? Because it stimulates sympathetic nervous system by increasing circulatory catecholamines like epinephrine and norepinephrine, and peak occurs in 2 to 4 minutes and then come to normal after 10 to 20 minutes and bring out following changes. It increases blood pressure, so that's why it can be used for patients with hypotension. It increases cardiac output and it dilates the bronchi. That's why it's very good for patients with asthma. But side effect of ketamine is also very important to learn about. The most important side effect of ketamine is emergence delirium or phenomena. Emergence delirium or phenomena means the patient will experience transient delusion, hallucination when patient wakes up. But if you want to get rid of this, or if you want to prevent this emergence delirium or phenomena, then 5 minutes before administration of ketamine, give 0.2 to 0.3 milligram per kg of diazepam. So then patient won't have transient delusion or hallucination when he wakes up. Second important side effect of ketamine is dissociative anesthesia. Why dissociative anesthesia occurs? Because there is dissociation of thalamus from limbic cortex of the brain. So how you know it? What are the signs of the dissociative anesthesia. Patient breathe, open eyes, swallow, move involuntarily, muscular, and there is muscular rigidity, so limbs remain in whatever position they are placed. But good thing is patient doesn't feel pain and does not remember the procedure. So these all were the examples of parenteral general anesthesia. Now we jump to inhalational general anesthesia. Inhalational general anesthesia has a small therapeutic window. What does this mean? This means that there is a toxic dose and therapeutic dose are very close to each other. That's why you have to be very careful with the dose calculation of inhalational general anesthesia. They are of two types. One is gaseous inhalational general anesthesia, which is gas at room temperature, and volatile inhalational general anesthesia, which is liquid at room temperature, and have following common side effects. Means all the inhalational general anesthesia are having some common side effects. Number one, the blunt sympathetic response to hypoxia. So symptoms of hypoxia such as tachypnea means increased ventilation, and tachycardia means increased heart rate do not appear. So what will be the solution? During the administration of inhalational general anesthesia, you should monitor the peripheral arterial oxygen saturation. It increases cerebral blood flow, thus increase intracranial pressure. So you cannot use it for patient with head trauma or mass occupying lesion in the brain. It causes vasodilation, which leads to hypotension. It causes respiratory and cardiovascular depression. That's why, but this is dose dependent. And one important side effect of inhalational general anesthesia is malignant hyperthermia. What is the cause of malignant hyperthermia? There is genetic predisposition, like it is autosomal dominant, and there can be mutation in ryanodine receptor 1, due to which calcium-induced calcium release is there, or mutation in sarcoplasmic reticulum of muscle. Therefore, endoplasmic reticulum cannot sequester the calcium after muscle contraction. But if anyone who is having genetic predisposition, the symptoms only appear when there are exposure of triggering agents. The triggering agents can be inhalational general anesthesia, all the inhalational general anesthesia except nitrous oxide. Nitrous oxide does not cause malignant hyperthermia. Or there is another triggering agent, that is neuromuscular blocker. Not all the neuromuscular blocker, but only depolarizing neuromuscular blocker such as succinylcholine, which is also called succinylcholine. Now, what will be the symptoms? There will be extreme muscle contraction, which leads to lactic acid production and increased body temperature. And what will be the intraoperative signs? There will be tachycardia, masseter muscle spasm, and rise of end-tidal carbon dioxide, EtCO2. Now, if you see that the patient is having malignant hyperthermia, then how are you gonna treat him? Give 2.5 milligram per kg intravenous dantrolene and repeat the dose until the symptoms subside. And what is the mechanism of action of dantrolene? Dantrolene inhibits the release of calcium from sarcoplasmic reticulum by binding to ryanodine receptors. Now let's talk about nitrous oxide, which is gaseous type of inhalational general anesthesia. It has low blood gas partition, therefore has rapid onset and rapid recovery. Now what is blood gas partition? It is concentration of drug in blood over concentration of drug in alveoli. If a drug has high blood gas partition, it means it has high solubility in blood. It strongly binds to serum proteins and have slow onset and longer duration of action. On the other hand, if a drug has low blood gas partition, it means it has low solubility in blood. It means it isn't bound with serum protein in the blood and have rapid onset and shorter duration of action. So nitrous oxide has low blood gas partition. It means has low solubility in blood, and it is not bound to serum proteins in the blood, and that's why it has rapid onset, shorter duration of action, and there will be rapid recovery from the nitrous oxide. But you should also know that nitrous oxide has low blood gas partition coefficient as compared to the rest of inhalational general anesthesia. However, all the inhalational general anesthesia has low blood gas partition coefficient. They are all less soluble in the blood. All of them are having shorter duration of action and having a rapid recovery. But as compared to nitrous oxide is having lower solubility as compared to the rest of the inhalational agents. The only inhalational agent which does not cause malignant hyperthermia, we discussed about this, that it is not the triggering agent for malignant hyperthermia. It is a potent analgesic but weak anesthetic agent. So it can be used as analgesic, but it produces very weak anesthesia. For obtaining full anesthetic effect, patient must inhale 100% pure nitrous oxide. It means inhaling pure nitrous oxide leads to hypoxia because you give the patient 100% nitrous oxide without oxygen. Since nitrous oxide blunts sympathetic response to hypoxia like tachypnea or tachycardia do not appear, and this can be life-threatening. So nitrous oxide can be used in two ways. Number one, as analgesic for dental procedures or other minor surgeries. So there is combination of 50% nitrous with 50% oxygen, and this is called Antonox. You can also use it as anesthetic agent, not by giving 100% nitrous oxide to patient, but you can combine nitrous oxide with some other inhalational agent. So there is combination of nitrous oxide with inhalational agent, and this combination lowers the therapeutic dose needed for that particular inhalational agent which you have combined with nitrous oxide, and this is called second gas effect. Let's know about the second gas effect. Nitrous has low blood gas partition than other inhalational general anesthesia. We know about this. We have studied about the blood gas partition, and we know that nitrous has low blood gas partition than other inhalational general anesthetic agent. Therefore, less soluble in blood, which leads to rapid uptake of nitrous from alveoli, leaving behind high concentration of that particular agent which is being used with nitrous oxide. So fraction of alveolar concentration over fraction of inspired concentration increases. Let's look at this part. The FA and FI ratio of the nitrous oxide is maximum as compared to the rest of the inhalational agent. And here you go. You have to look at the blood gas coefficient of nitrous oxide, and this is having the lowest value, and it is having the lowest solubility as compared to the rest of the inhalational agent. So, but you should remember, there is a note, a very important note. Nitrous is less soluble in blood than other inhalational agent. Therefore, having low blood gas partition coefficient as compared to other inhalational general agents, as we have discussed it already. This is important. That's why I repeated it again and again. When patient is recovering, now you should know about this as well, that if it is having low blood gas partition, then it must have any other problem as well. When patient is recovering from nitrous oxide, large amount of nitrous oxide rushes from the blood into alveoli and causes transient hypoxia, and this is called diffusion hypoxia. Solution for that is, during recovery, give high fractional inspired oxygen concentration. Now, side effect of the nitrous oxide: it inhibits methionine synthase, which normally converts homocysteine into methionine, and methionine is used for DNA production. So when there is no DNA synthesis, this leads to megaloblastic anemia. Remember this, it expands the trapped gases in closed body cavities. So that's why absolutely contraindicated for pneumothorax and bowel obstruction. Now let's jump to the next example of inhalational general anesthesia, that is halothane. It dilates the airway, that's why it can be used for asthmatic patient. It is a potent anesthetic but has weak analgesic. So that's why when you give halothen, you have to combine it with any other analgesic agent. It causes skeletal and uterine muscle relaxation. So what are the side effects? Hepatotoxic, therefore rarely used these days. It causes atropine sensitive bradycardia, means when bradycardia is produced, you give atropine, then bradycardia can be reversed. It causes hypotension by vasodilation. The next example is isoflurane, most commonly used with nitrous oxide as maintenance. In a lot of operation theaters, the isofluranes combined with nitrous oxide and oxygen. What are the side effects? Produces coronary vasodilation. And good thing is, because it causes coronary vasodilation, it increases coronary circulation and can be used for patient with ischemic heart disease. But it, because of vasodilation, because of coronary vasodilation, it causes coronary still syndrome. That is hypotension due to coronary vasodilation, because all the blood is being directed towards the heart and there will be drop of blood pressure. Methoxyflurane, it causes nephrotoxicity, therefore rarely used these days. Desflurane, it can't be used as inhalational induction. Why? Because it causes cough, bronchospasm, laryngospasm, excessive bronchial secretion due to airway irritation caused by it is pungent and musty smell. So instead of desflurane, sevoflurane can be used for inhalational induction, especially in pediatrics. Influrane, it causes nephrotoxicity and it also lowers the seizure threshold, so completely contraindicated in epilepsy. There is one kind of analgesia that is called neuroleptic analgesia. There is a state of deep sedation and analgesics used for minor surgery. There's combination of antipsychotic drug like droperidol and opioid like fentanyl, so to produce deep sedation and as well as analgesia or painless condition. Thank you for watching this lecture till the end. If you found it helpful, please like, subscribe, and share your feedback in the comments. For complete lecture notes, you can follow me on Udemy. And this clinical anesthesiology and pain management is having 7 parts. Make sure you watch all of them so that you should not miss any information, knowledge, and see you in the next session.